Get the brain, get the brain, get the brain, no. Stand up, move the blood. It does help, doesn't it? Wakes you up a bit. What I'm going to do now is talk about doing the isolated CVP compared to continuous things. Do you want to? I can pause this. I can pause it if you want. All right, I'll just continue on, please. All right, so. And the reason why I got you to shake your booty is because this is actually takes a bit of concentrating. Now,
you did say continuous CVP.
You can do a continuous right atrial pressure rather than CVP, but this is looking at that static type of measurement that we do, like a CVP or whatever. First of all, there's the oxygen delivery state, and you can see cardiac index times by hemoglobin, yeah. Oxygen saturation plus a variable figure there. That is your oxygen delivery state, and we have our hemodynamic state, which tends to be more so our mean arterial pressure. Then we look at these things, preload, contractility, afterload, which are our hemodynamic modulators, and what we tend to use for those is your CVP, your MAP, and your wedge pressures. Very familiar with that sort of practice, but we could do it another way. We could do it instead of every hour or 3 hours or 4 hours or whatever, we could do it every beat, every heartbeat, and it would give us a lot more information. So, in fact, what it would do would be not just oxygen delivery, but it would also tell us about blood flow and perfusion, and plus the hemodynamic state. But we could do it through a continuous cardiac output modality. We could look at continuous echo, and we could look at stroke volume variation as well. So let's have a look. This is the vigilance monitor, which does a continuous cardiac output with the pulmonary artery catheter. Yeah, and it does an SVO2, and it does your cardiac output. And obviously it can do your cardiac index as well, and continuous cardiac output. And it does a few other parameters that you want, like SVR and things like that. End diastolic volume index, your SVO2 there. Yeah. So, yes.
Is that the core with the
No, this is the continuous pulmonary artery catheter.
Oh,
It's, yeah, this isn't. Sometimes you have, yeah, but I don't think you use the continuous. Yes. No, this is very expensive to do, and that's why every patient doesn't have it. But you will see it around.
but that's the same heat catheter that you use.
It's a more expensive one because it does it continuously.
So it's a
Yeah.
little different here.
A little bit different, yeah. Okay. So, yeah, so it goes in the same position, and you have to do some different calibrations, but it does give you the same thing. Okay. Then we have the PICO. And PICO is a lot cheaper to use than the pulmonary artery catheter that does continuous cardiac output. And you can see it actually works this out by using the stroke volume. So 80 mils, 50 mils, blah, 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 converts that to a cardiac output with a calibration technique and some thermodilution. And I've given you a full sheet of this one too, so you can actually see the printout there. But if you look at PICO, this is the PICO Plus, so this is the second to third model along from when it was first brought out, so it's a lot more sophisticated. And you can see it does basic stroke volume, does heart rate, SVR, stroke volume variation, which is only 6%, so the patient's well filled. And you go further down, it does the cardiac outputs every 2 minutes there. It sort of does those static things. Contractility actually does a cardiac function index, which gives you a measure of contractility, which is very useful. Further down, it does global end diastolic volume and interthoracic blood volume, and your extravascular lung water number there. So they're all really useful things. They look at different compartments and give you an idea of what's happening in different compartments, because that's the one trick to blood flow, is it does have its compartments, and we guess a lot of the time.
So cardiac function index and cardiac index the same?
No, cardiac function index is a logarithmic calculation of what your contractility is.
And there's no CI in that one?
No, because that's about contractility. Cardiac index is about your cardiac output in its volume rather than as a measure of strength.
Okay.
So this is more of a measure of strength of your contractility. And of course, your echo does give you per beat haemodynamics there, which we all know. And here it goes through the right. When they do that, if you've seen echoes being done at the bedside, the ventricle, and often they do it with the colour that goes through it. At the top is actually blue and red. And you can see the oxygenated and the non-oxygenated blood. The top bit is where the ventricles are. So whenever you look at that, it's looking from the atrium up. So you can actually see, and the left ventricle is usually the one on the right side. So it's the opposite to what you would see. Yeah. Okay, so is it more efficient, more effective to do things per beat? Let's have a look. We have here on the side here cardiac output.
We won't be changing anything every week.
And why do you think I'll talk to this in a sec. If we did everything every beat, it'd probably be more expensive. Okay, so, that's in the real world. We've got to look at it. Okay, but if we had, a single pulmonary artery or even a central line, and, some countries can't afford even that with their patients. Their shock patients are managed purely on clinical presentation. But, okay, so we've got cardiac output there, time across there on the x-axis. And you can see that if we do continuous cardiac output, we have an orange line there. The little dips, But if we do it sort of every hour with a bolus thermodilution from pulmonary artery catheter, it gives us a picture, but we miss a little bit in between. So, is that going to make a difference to outcome or to some form of measure? In fact, what it meant in this group of patients, there were two groups. The ones that they had their cardiac output done 4 hourly actually used a lot more epinephrine or noradrenaline in their infusions than the ones that had continuous cardiac output. Because, and that's probably beneficial for the patient. And as far as giving them colloids, and if that tends to be expensive colloids, not just starch ones, you can see that they give less fluid to those that have continuous cardiac output. It's more precise filling, So that's good. And in a group of patients, cardiac surgery patients, this protocol group had continuous cardiac output according to those that didn't, and it ended up there were less complications in this group. What they don't tell you is there's more death, but I'm not sure they haven't adjusted it for severity of illness or anything. What I found interesting was in more people with AF, which is really a surrogate sign for inflammatory response and autonomic nervous system dysfunction. So they obviously had a bit of nervous system failure there, which which was interesting. Okay, so we have 2 patients at the back there. We've got them. Let's have a look. So you can scribble on that if you want to. All right, so we've got 2 patients. We've got a male who's 84 years. Seems to be our population at hand. We've also got a male over the other side who's 24 years. Yeah, fairly young. Now the HO is 0 hours, the H2 is 2 hours. A HO there is 0 hours, and we have 5 and 6 hours, okay? Parameters, we've got temperature, mean arterial pressure, heart rate, SpO2, which is your hemoglobin there, your lactate, your cardiac index, your SpO2, and your oxygen consumption. So let's have a look at this elderly gentleman. He presents with I'm not going to worry about what type of shock it is. I'm going to ask you about perfusion, you know, and oxygen delivery, because really that's what we're looking at. We've got a male, 35.2 temp. It's warmed up a bit. We have a male who has a very high fever, and he cools down a bit. The first male has mean arterial pressure of 65. That rises over 2 hours to 68, and our younger chap has a very low mean, and it rises to very high, doesn't it, the mean arterial pressure? Heart rate in the elderly gentleman, 65, that rises nicely, and the patient 2, very high heart rate, and that reduces down there. Now, SpO2, we've got 100% on this gentleman, and we have, you know, 97, 96, that seems fine. Hemoglobin, yeah, okay, so, you know, 11 or 110 if that's how you measure it. Yep, and patient 2, he's got a normal male hemoglobin of 136. But we go to serum lactate. Look at that lactate. That lactate is normal, but we have a lactate here which is off the charts. Yeah. It does reduce though, and it reduces quickly, which is good. So they've obviously had intervention there. Cardiac index, a bit sluggish with our elderly gentleman. And we have, with this young guy, he obviously became hypodynamic there, hasn't he? Probably. And we know that that's sepsis because he's got a fever. But this guy here's probably got sepsis too, because he's got a response, like a lot of old people do, that they don't have enough adrenaline in their system, and they don't have enough. They're also corticosteroid tolerant, in terms that they don't have enough cortisone in their own system to be able to respond in an inflammatory way. And a lot of those patients that present who are sepsis obviously often have, they're cold, what's called cold shock. And they're the ones that sneak under the radar, because if you look at those hemodynamics, they're not unremarkable. SpO2 here, 65. Oh, that's normalish, but we've got a very high one here, so hypermetabolic. Oxygen consumption, what's the normal rate there? Oxygen consumption. Have a look. 120 to 170, so oxygen consumption is quite low, which affects the metabolic rate. And it picks up a bit as he warms up. But this chap here, he's got a very high oxygen consumption. Yeah. Now my question is, do we have hypoperfusion here? Okay, so tell me, what are we looking at?
We're looking at maps and heartbeat.
Maps, okay. Yeah. No? Maps a bit low? Yeah? He might be on beta blockers. We really don't know with this guy. Cardiac index is a bit sluggish too, isn't it? Yeah. So he probably does have hyperperfusion, but it's one of those ones that's sort of insidious. So where do you think we'd send him to or have done with this chap? He's mechanically ventilated and has sedation going, and he's been identified clinically as being quite sick. Yeah, sorry, I didn't mention that, it was up the top. Yeah, but you know, he's one of those ones that you would probably do your echo on and you'd sit on for a while because you would suspect, and from experience you've seen this presentation before, cold shock presentation, and you knew that something, you know, if you didn't get in there early with resuscitation, that this patient would go downhill very quickly. But this is a young guy, obviously, with something like influenza A or one of those really bad infections that is hyperdynamic, is very hot, very high metabolic rate, and we keep him filled and resuscitate him early, and he will probably do quite well with some antibiotics early as well. Yeah, but he's far more overt in the young, and in children not quite as much, but in this age group you pick shock very quickly. But you don't in the elderly and you don't in the very young. I'll leave it generally at that. Okay. Your goals are optimising perfusion, optimising your stroke volume and your cardiac output, ensuring they've got good contractility as well as being well filled, optimising preload, seeing if they're fluid responsive. Don't just trust that when they're prescribed fluid that they'll need it, because you're the advocate for the patient. Have a look at them and think about their fluid responsiveness. I know that in some units, and you know this one here too, that they like to run their patients very dry. So they will allow they'll allow the patients to slip down the curve a bit if their cardiac output is okay. And some patients who've got very big floppy hearts will only have a very small window of filling, like they'll only need 125 mils to suddenly be on top of the curve again. And that's what we're seeing a lot of now, so that's why we're very cautious with our fluid and our fluid boluses to avoid pulmonary edema. So, definitive questions? Is hypertension necessary for the diagnosis of shock?
No, not one. Well, it's a very late sign.
It's a very late sign, isn't it? And it worries me when I see these charts written up for the deteriorating patient in the wards. You know, you want what I mean? What I'm talking about? No? You know how... Yeah, there's some, with the Australian Safety Foundation is looking at some charts, flow charts for patients that pick up on vital signs changing on the ward so they can call a MET call, for example. But again, that hypertension is a late sign, so having just a chart that does that doesn't actually cover your patient, because there's clinical subjective signs that we all know and love that don't come across in a chart. So when should we monitor stroke volume or cardiac output in shock? Right from the beginning, I would have thought. And you don't have to have a lot of invasive stuff in situ to do that. You can feel pulse pressure just by feeling your pulse. You can look at your GVP. You can see, in fact, how they're tolerating. You know, if someone can't sit up, because they've got low perfusion to the brain, they'll want to lie down. They'll position themselves accordingly. So there's lots of signs you can look for. Okay, so what are the markers of regional and microcirculation that can be monitored about cellular function? We looked at lactate, but what else can we look at? SpO2, yeah, we can. Voice. Sorry?
Urine output.
Urine output, yeah, fantastic, yep.
GCS.
Oh, your GCS, your Glasgow Coma Score.
Yeah.
Sometimes there's a lot of things which change your way that you respond. It's not always about perfusion, but it may be about perfusion. What about your blood gas? What do you look at that? Yeah, just an acidosis and your base excess, you know. Some units don't measure lactate, do they? They look at their base excess instead. Yep. Which gives you a broader look at acidosis. Okay. What is the evidence for using hemodynamic monitoring to direct therapy in shock? Yeah, it's all about your patient, and the more bits of lines and stuff you use has no relationship with outcome at all. So even those patients that are managed well with minimal invasive therapy that's very tuned in clinician to the patient and clinical signs can manage a patient just as well as if they put in all the fancy stuff. Yep, that can happen. But hemodynamic monitoring can help us understand it a bit better. So, anyone got any questions at all?
That should be on the emergency front.
It should be, shouldn't it?